Hi guys. So the final presentation that I want to look at is more of kind of an update. It's not something that we're actually going to cover. As you can imagine, you know, instigating head injuries is probably frowned upon in practical classes. But no, in all seriousness, I wanted to kind of cover this because it's obviously very current. It's obviously very controversial, depending on which sport you follow. And it was just sort of for me to kind of give you an update. One of my other roles is I assess trauma management for the RFU, and those guys are typically well ahead on things like this. So it's to kind of give you an update as to how to assess it from a physio point of view, and ultimately the best thing is how to manage it, and what are the guidelines in returning to play. So the first thing that I want to kind of come across is really, well, what is concussion and how does it affect performance? How can it affect performance? What signs, ultimately can you look out for? And then just give you a little bit of information about the management and ultimately the return to play. So what is it? Well, concussion is a brain injury. It's diagnosed as a brain injury, and you don't have to lose consciousness to suffer concussion. In fact, only around 10% of concussion sufferers actually lose consciousness. So consciousness is a really poor indicator of the amount of injury that the brain may have sustained. And there are rapidly sort of changing clinical signs and symptoms associated with it. There is a pathophysiology to it, and we will discuss this later on. But there is actually a pathophysiological change that happens within the brain that is evident through scans. In terms of injury occurrence, in rugby union, nearly a third of time lost injuries is down to. Has been shown to be down to concussion. That is a substantial amount of injuries. If you think of all the injuries in a season, and nearly a third are through concussion, that is quite something. Unfortunately, and of course, this is why it's in the headlines more often than not. Is the compliance to it is poor. The compliance to the guidelines is poor, and that's something which ultimately we as physiotherapists working in elite sport really need to be on the ball with and be aware of those guidelines and comply to them. And I'm going to show you a little bit of a video here, and this is a good example of what startled me. I am guilty of being a little bit of a cricket fan, and for those of you that don't watch it, then you might find this relatively dull, but for those that you do, you A, probably remember it, and B, will know I'm about to show you. And I'm going to show. I'm going to go to a particular point in it. I've just got to do the old sort of browsing, as it were, to try and get to the actual point. Will it let me drag? It's not. Well, what I'll do, it's not going to let me. It's not going to actually let me skip it. So it's only it's less than 2 minutes in. So I'll kind of talk around it. What you will see is an Australian cricketer being hit in the head with a ball. And for those of you again not familiar with cricket, that ball is predominantly a soft piece of wood, basically. And just to kind of go through over the stats around it. Is the ball that was bowled was just over 90 miles an hour. So it gives the player less than half a second to respond. And you will see how this was managed. And for me, this didn't really get enough sort of criticism really at the time. I was quite surprised with it, really, particularly given how other team sports have been kind of criticised with it. So you will see that the physio will come on and perform. That's a near miss. So you can see the pace at which he's about to be hit. The physio comes on, does an assessment, and we talk about in the previous one in terms of return to play, external variables. What you will see is that that Australia start to lose a few wickets, and they bring him back out. So there he is. That's him being hit, and about 90 miles an hour. You can see he's not in a good state, and he goes from the field of play, quite rightly so. And obviously he'll be assessed there. And then this starts to happen. Then Australia start to lose wickets. And of course, of those of you familiar with cricket will know that England-Australia is a big, big rivalry. And so what happens is they bring him back out. And he starts to do okay. But then he starts to hit a few and you think, oh, maybe they've got away with it. But then you can see him start to deteriorate. And actually, when he gets out, when you analyze what happens and what could have happened. So that's when he gets out there. Now, look at, he's not offering a stroke at all. He's not offering a stroke at all. Now, if you think that he could have been hit again at 90 miles an hour, if you think that he would have suffered potentially another concussion, that's relatively frightening, and there is, which we'll discuss later on, in terms of something called second impact syndrome, where people have died from that happening, and it absolutely took me by surprise to see that happen. This is taken from the RFU guidelines in terms of managing concussion, and they will refer to as the 7 R's really. The first one obviously being able to recognize a head injury. So that's the first. Then going on to your initial on the field evaluation. If suspected, remove. Okay, remove and refer immediately. Okay, and that's what wasn't done in the previous clip that we saw. There was no referral onto a medical examination or certainly a doctor. If it is confirmed, then the player has to have physical and cognitive rest until completely asymptomatic. So, you know, in terms of dizziness, headaches, stuff like that, blurred vision, that has got to stop. Okay, so that's what we mean by physical and cognitive rest. All right, so not even light training or non-contact training, complete rest. And then ultimately there is a recovery in terms of a graded return to play, which we'll discuss a little bit later on, and rehabilitation, and then ultimately a return to play. So that's kind of how the RFU kind of, in terms of an overview, deem a successful and appropriate way to bring players back to training. So this is something I want to discuss because it's something that's been recognised relatively recently, probably certainly within the last 10 years, that there is actually a pathophysiological change. The bad news is, well, it doesn't know actually what happens. And in terms of the sequence of events, they're currently disputed. So our knowledge of the actual pathophysiology is poor. However, what is irrefutable is there is a reduction in cerebral blood flow. So when they've done scans, MRI scans on sufferers from concussion, you can actually evidence that there is a reduced blood flow in the cerebral area of the brain. And ultimately, this is why rest is required. There's also changes in the white matter of the brain. Again, this is not universally agreed as to what those changes are and whether they're kind of universally seen across all patients, but there is changes in the white matter of the brain. And these effects can be persistent up to 7 months post returning to play, depending on obviously the severity of the concussion. And there lies a problem, doesn't it? Because, you know, one of the things that we said in terms of the return to play protocol in my previous slides is we have to be objective. And if you are seeing changes on a scan, see changes on a scan in any other soft tissue, would you send them back in? Probably not. but yet it's something that we're doing with the brain. And it's a difficult one. It's a difficult one. What I would say is if you do work within academy level football or academy level sport, whatever, really, your pediatric brain is more susceptible to developing concussion, and always err on the side of caution with any kind of pediatric sort of effects of concussion. I know there's a big movement in football to try and remove things like heading, repeated heading out of academy levels because of the now known kind of effects of repeated heading contact with the ball. So what's the effect? Delayed reaction time, as we saw in that video that I showed. He literally just stood there and the ball hit him, and he was very, very lucky that the ball hit him on the pads and not anywhere else. That can take anywhere between 2 and 3 weeks to recover. Okay, so when we're talking about rest in terms of one of the R's from the RFU protocol, that could be 3 weeks. Okay, you cannot send somebody back in to training with delayed reaction time. Okay, we already know the effects that can have. There's a reduction in mathematical and spatial processing. So if I was to be really kind of go into depth with this, if we think about people's awareness of proprioception and the computing how quick someone's coming and how far off they are in contact sports, that's reduced. So that can be dangerous. And actually there are studies shown that somebody's risk of developing other injury after concussion goes up by nearly 1/3. So not another concussion, but say a hamstring problem or any other soft tissue, because of these kind of components. In terms of cognitively, there's reduced memory, attention, and sort of executive function. Okay, again, there's things like hindered balance. All right, that can come back within days for adults, but look at that for adolescents, up to 4 weeks. Okay, which is why if you do go and work in academies, guys, please be overcautious. That's the only one I'm saying be overcautious with in terms of the head injuries. Again, Parrington did a really nice study in terms of looking at things like gait and postural sway, and they found that just standing, there was an increased postural sway. So the athlete's inability to remain still post concussion was increased on standing. And again, in the acute phase of concussion, multiple studies shown that gait speeds are slower. So there's an awful lot of effects of concussion, and which is why it shouldn't be taken lightly. Which again is one of the things that amazes me, but not in a good way, in terms of how this is managed and how I've seen it managed in supposed elite level sport. We've used the example of cricket, but there's numerous times in football where it's been badly mismanaged, and it's worrying. It is worrying, and it's something that hopefully will certainly improve over the next few years as you guys become involved in it. And as I've mentioned before, I wanted to hit on something called second impact syndrome, and it's a rarity, but it relates to the pressure in the brain and the effect that a second impact can have, where the pressure in the brain builds up that the body can no longer control it, and ultimately result in death. So, you know, things like that, when we see players being put out in the middle of the sporting arena after suffering a concussion, is something certainly worries me, and kind of what has to happen for things to be taken seriously. Again, if you look at when we talked about the shared decision-making process in the previous session, that players should not have a say in concussion. If you look at a lot of the rugby union guys now and the players that are coming out and talking about this, and they are agreeing that the players should not have a say. Now, we don't know what went on with that particular cricketer. I imagine that the loss of wickets put pressure on him to come out and bat, which is concerning. and as I say, our knowledge of concussion and the impacts it can have as physiotherapists, as health professionals working within elite sports or whatever you come across semi-pro sport, has to be better because of the potential impacts it can cause. So in terms of assessment and management, there are different things out there, and some of this relates to trauma management and pitch side assessment, and some of you may be lucky enough to be able to go on one of these courses if you do work in elite level sport, and they will talk about what's called the AVPU scale, which stands for alert, verbal response, painful response, or unresponsive. So, you know, ultimately anything less than an A, the player's coming off, and you've got to suspect that there's been a head injury there. It doesn't mean that if someone's received a concussion that they can't be alert. Absolutely, in terms of how you would deem alert at the side of a pitch, they can still have concussion. And one of the things that is used quite widely now is something called Maddox questions, which is something that you can print off. And I certainly used to have a copy of it in my my little run-on bag, because it's terribly embarrassing, isn't it? If you go on and forget the questions, there's some sort of irony there. But it's things like, you know, what half are we in? Who did we play last week? What's the score, etc. There's 5 kind of questions on there, and they're relatively easy to find. They're out there, and obviously, if you do suspect that, recognise and remove. Don't take any chances. Don't take any chances, and hopefully, the pressure will come off health professionals with the you know, introduction of things like head triages, which they do have in both codes of rugby now, and concussion substitutions, which is coming in football. It's taking its time, but hopefully that should be here sooner rather than later. So hopefully there will be less pressure on health professionals to diagnose and recognise it straight away. And these are some of the questions here, Maddox. As I said, it's out of 5. What venue are we at? Which half is it? Who scored last in this match? What team did you play last week? And did your team win that game? Relatively straightforward stuff. And there is a child version as well. And I will tell this story. There's a really funny story in football about why you would use Maddox questions. And that's to do with a player that many of you may have heard of, a guy called Robbie Savage, Welsh international footballer. There was a corner that came over, and he basically got hit in the head with a ball, and he went down, didn't lose consciousness, and the physio came over and started asking him questions, and he said, he asked the question, who is the current Prime Minister? To which Robbie Savage replied, I don't know. So the physio, doing what he thought was right, made the signal to the bench. Okay, the X means obviously he can't continue. The spinal board came on. He was put in a neck brace. Blah blah blah. Oxygen, everything like that. And it actually turned out that he didn't have concussion. The player just didn't know who the Prime Minister was. So I quite like that story, because I think, you know, I think the physio did the right thing. But you've got to be careful which questions you ask, and that's why I would encourage, and certainly I used to use the Maddox score, because, you know, you don't need to be necessarily intelligent to answer the questions. There's something that you can use called a SCAT-5 questionnaire, which is something that you can use if you do have the opportunity to have a triage. And I've put a hyperlink there as to where you can download the form, and it's very, very self-explanatory. It's quite in depth. There is a different version called SCAT-3, which is less in depth, but certainly the Rugby Football Union use SCAT-5. And it tests cognitive, somatic, and neuromuscular status. So it's quite in depth. It's not something you would do on the side of a pitch or on a pitch. You would go into kind of a triage sort of setting to be able to deem whether they can carry on or not. And it's something that I used to use when they were doing a graded return to play. So I have a sort of an update that tests everything, really. So really, really useful. In terms of timing, it's not really been agreed, because the evidence isn't there to support it, in all honesty. And the evidence around concussion is still very much in its infancy, and is only going to get stronger as over the next 5-10 years. So the timing isn't agreed. And when I think back, and certainly the advice I was given back in the mid-noughties, that I sent someone back after 7 days because they were symptomatic. They were asymptomatic after sort of what I thought was great, which it was. He went from absence of symptoms to then cycling to then jogging to then change the direction and stuff like that. And yeah, I mean, thankfully everyone was okay. There was no problem, but it's difficult, and I think that the problem that we have at the minute is, and what I'm trying to get across is that you can't just go off patient symptoms, because the self-reported symptoms such as the dizziness and the headache and stuff like that can be resolved within 6 days, but it's not taking into account anything else that's going on, and any swelling around the brain or reduced blood flow. So it's something that that we need to consider, and that's why the SCAT5 is quite nice as well, because it does take into account things like neuromotor control and things like that, and that's always good evidence to use and to have as objective as you can be, really, in terms of a guide that you can use to progress or not. I mean, ultimately you can't scan someone every day. Well, you could if you're in Man City, I suppose, but you can't scan someone every day to use that objective nature. And the trouble is that the vast majority of return to play criteria out there still use cognitive recovery, but actually only 2%, would you believe, use any form of physiological testing. Ultimately, yes, people get away with it to a certain extent, but should we be taking a risk with something like this? No, we shouldn't, is the honest answer. And so something that I follow, and I've literally taken this from the RFU, is different rehabilitation stages. Now there's no there's no timing on that, but there is a nice progressive return. And it even gives you some kind of exercises at each stage and the objective and how it's contributing to the effects of concussion. There's a bare minimum of 24 hours at each level, so it's not one session, and it might be that you extend it over, certainly at number 2, of course, you extend that over 3-4 days, and with the RFU, they say that you have to get medical clearance before you go into full contact practice. So between 2 and 5, so going 4 to 5, you do need that full clearance, which is easy if you're in an elite sport club who has a full-time doctor. If not, such as certainly when I was at Burnley, we would, you laugh and joke, but we had to go and arrange to see the local GP who kind of was part-time doctor. It's something that you need to do, and I think that you need to be clear about where you're going to seek medical advice, and that for me on there is getting it to number 5, is getting that is getting that medical sort of input, really. If symptoms occur, you drop back to the previous asymptomatic level and rest for 24 hours. So it's you can go backwards as well as forwards with it, and it's important that you recognise that. But this is quite a nice one, and again, this was something that was printed out and stuck to the physio room wall, just so that everybody knew where they're up to with it. There are some different categories. So the RFU, slightly different in terms of what they would consider professional. So they consider over 20s kind of in the men's category, which is why they use that particular time frame. And you can see there that they separated it into routine, which is kind of your semi-pro, and your enhanced care. So if you're working in a semi-pro, there's a rest for a minimum of 14 days. Once cleared by a healthcare professional, you can then start to begin the gradual return to play, as on the previous slide. And that's got to be overseen, though, even though you might not see them all the time. It's got to be overseen by somebody who's graduate return to People have actually got to observe them doing these exercises rather than just going off on their say-so. And then on completion, they've got to get a clearance from a doctor. So the earliest you can get back is 19 days in a routine setting. You go over to the enhanced care setting, which basically means your elite level club where you have a full-time doctor. Then you can see the time frame comes down considerably, and the earliest is 6 days. That does seem, on the face of it, that does seem very, very quick. However, what I would add is that you can see that they're getting cleared at each stage by a healthcare professional and ultimately from a doctor. So there is that support there. So the players are getting that daily support to be able to, for that to happen. Change slightly if you're under 19. You can see straight away. I'm not going to go for each of them because they're relatively straightforward. But you drag it out. So in terms of an enhanced care setting, you're doubling the time, and in a routine you're going from up to 23 days. So best part of a month. So again, it's worth keeping these in mind if you do go and work in those kinds of settings. And in terms of a summary as well, it's there by a flow chart if you prefer to see it like that. But you can see where the clearance is needed by the doctor, just to be absolutely clear. And then obviously in the enhanced care setting as well, the same thing. Okay, so that was just a bit of an update really on concussion and current thinking in terms of how to return to play, and current thinking in terms of the effect that concussion has. That may well change, guys. I dare say it will over the next kind of 4 or 5 years. So it's well worth, if you're going to go into the sports setting, being aware of it, particularly if you're going to work pitch side, so either a trainer or a match, and to recognise it. I've put hyperlinks in there for you to access the SCAT 5 questionnaire, and with the others, feel free to to print the slides off and use them yourself. It's not a problem. But some good reading here, guys, as well. I recommend that you would read the Parrington study, the 2019 one, the third one down there. That gives you a really kind of good grounding in terms of how to assess things like balance and gait after concussion. The very bottom is the current World Rugby guidelines, the concussion guidelines, and I tend to point people towards that just because of the sport they're certainly quite far ahead in terms of other sports, and really leading the way. So their guidelines are ones to follow, really. Certainly as I have done in my practice, I've tended to use the RFU guidelines. So hopefully that's been of use, guys. As I say, it's not something that we're going to overly cover in the practical sessions, but something that I wanted you to be aware of, and to have resources to help you, for the immediate future, should you go and seek employment in there. So as I say, hopefully that's been helpful. Again, any questions related to this, I'll open the discussion board, and you can ask me any questions there, no problem at all. All right, guys, so I hope that's been helpful, and that's essentially all the pre-reading or the asynchronous lectures to do. Again, I would encourage you to engage in the reading. It's going to help you, because ultimately in the practical we will essentially be applying all these principles. So it's really important that you have a good grounding, a good understanding of these principles to be able to apply. The practicals themselves is not me giving you a library of exercises and going, there you go, there's a pen drive, crack on. We're really looking for you to understand those theoretical concepts and those principles to be able to apply to a case scenario.